All right, I think we'll go ahead and get started then. I am happy to welcome everybody to the Canadian SADS Foundation's webinar, Exploring the Complexities of Brugada Syndrome in Children. On behalf of the Canadian SADS Foundation and our presenter, thank you for joining us today. I'm Anna Goodson, Communications Director for the SADS Foundation in the US. It's my pleasure to introduce our presenter who is volunteering her time and expertise today. Cecilia Gonzalez Corcia is a clinical associate professor of pediatrics at the University of Montreal, Canada, where she is also the associate director of their pediatric and congenital arrhythmia service and director of their pediatric electrophysiology senior fellowship. She is a pediatric and congenital cardiologist with an expertise in electrophysiology, devices, and inherited cardiac conditions. Following her presentation, you'll have a chance to ask your questions. Please type your question into the chat field and we'll address them at the end of the presentation. Please keep your audio microphones muted during the presentation as it helps with the recording quality. Now it is my pleasure to turn the program over to Dr. Gonzalez Corcia to get us started.
Thank you, Anna, and thank you to the SADS, Canadian SADS Foundation and US SADS Foundation also for providing this assistance and this invitation. I am so pleased to be with you today, and it's such a great honor also to have some relevant people working for a long period in the audience and which have become dear friends, as Pam herself doing her work in the Canadian SADS, and I see also Alice is in the audience, and Catherine as well. So all my hats to all these people, and it's really an honor to have them joining today and supporting this important research in pediatric Brugada. So I will start by sharing my screen. Excellent. And I thought today what we would do is maybe go through some of the complexities and the news we have with the pediatric Brugada research and the project that we have been working on for some time now. So we have been working for the last seven years in diagnosing and managing young children with Brugada syndrome. This is a difficult disease because it has challenges in adults who present them later in life, around the age of 40 years old, most of the cases. And the expression of the disease can vary a lot, and we have not really understood what leads to this expression or to this heterogeneity and diversity of expression. And this is in adults. When we come to children, things become still more challenging. Here we have all these small, wonderful, angelic faces. Many of them are maybe carriers, and our carriers belong to families with Brugada syndrome, and they may be carriers of a gene, but it's difficult to predict from these faces who is the one that will express the disease. We tend to think that children express the disease later in life, but we have encountered children presenting the disease very, very, very early. Here we have one of our patients from UK, from Bristol, who presented with sudden cardiac death due to Brugada syndrome when she was only 18 months old. So it has become really a challenge to screen these children, and we have been incessantly trying to go beyond our knowledge and to identify criteria and clinical parameters that could help us identify these children early so that we don't have to encounter the difficulties that this little patient had So Ellie Rose was 18 months old. She was a very healthy toddler when one day she presented with a cardiac arrest. She was lucky to be reanimated by both parents. We see them here in the picture by her side. And she did survive this arrest due to the early arrival of the paramedic system and transfer to our institution in Bristol. And she had a diagnosis and she had an ICD placed, but she was one of many. And we keep wondering if we could have done better and identified her disease before it expressed very early with a potentially lethal event. So for many of you that are not within the medical field, I prepared this slide just to remind you of how the disease is encoded in our genes. There's a variant in the gene that encodes for the main channel, which is a protein in the cells of the myocyte, the main cell of the heart. And this gene that is called SCN5A has a little variant, and we call variant the mutation, the abnormal sequencing of the genes. And this variant makes that the channel, this is a little door in the protein of the myocyte that allows sodium to go from the outside of the cell to inside the cell. This protein is abnormal. And within this abnormality, it reduces the flow of sodium across the membrane. So we call this variance loss of function because the channel, this little door, sees its function reduced due to this abnormality, genetic abnormality. And this impacts the overall electrical stability of the cardiac cell and result in several abnormalities in the conduction system and predispose the patients to abnormal ECG findings and also to develop several kinds of arrhythmias. So the reduced transfer of sodium across the membrane causes delay in conduction and some markers that can be evidenced earlier before children express potentially lethal ventricular arrhythmias. And this includes a dysfunction of the main pacemaker of the heart, that is the sinus node, and that's why we call this sinus node dysfunction, some delay in the prolongation in the upper chambers of the heart that are the atrial. At the atrial, this is called PR prolongation, and several degrees of blocking conduction between the atrial and the ventricle. And also there is fractionation of the conduction within the ventricles. So there are several different small abnormalities in the ECG that may allow us to suspect that there is an underlying genetic disorder before it expresses as arrhythmia or sudden cardiac death. So our little patient had this event. She finally survived this first event and did well with an ICD. And we have seen over the years, becoming experts within this field, we received requests of advice from several parts of the world, and we see that our young patients that either have a diagnosis of Brugada syndrome or belong to families where somebody has had sudden cardiac death or has a diagnosis of Brugada syndrome can have two very different scenarios. One scenario is the bright one, the children that belong from Brugada syndrome families, but are asymptomatic, have always been well, and have never expressed any manifestation of the disease. So for these children and their families, we have to make sure that their risk is low. We have to make sure they have a benign prognosis, and we have to follow them through childhood and adolescence into adulthood, making sure that they don't start to spread the disease. Okay? So this is the main cohort of patients that we receive in clinic. The typical example is somebody had a sudden cardiac death within their families, or had a ventricular arrhythmia and subsequently have been diagnosed with Brugada syndrome, either by ECG or due to the genetic test that confirmed a variant. And then the adult cardiology refers the patient, the family, to us to take care of the children and evaluate the risk and make sure that all the children in the family are protected, are not at high risk. So this is the majority of patients that we see as pediatric electrophysiologists. But as in the case of Ellie Rose, we have also patients that will develop a more severe expression of the disease and that will present very young, sometimes as the first in the family, with very severe disease. And the severe disease can be seizures that actually are not of brain origin, but represent arrhythmias that with low brain perfusion and seizures related to that, breath-holding spells, or sudden cardiac death. And these children usually need to have an ICD to protect them, because up to now is the only way that we have to protect these children in the case they develop an arrhythmia. So these are two very, very different patients, and we still do not know which factors can contribute, apart from the genes, which factors can contribute to a very severe and early expression of the disease in selected patients. So our aim during all these years has been to collect information from these families, either with children that presented the disease themselves, and those are called probans, or children that belong to families with Brugada syndrome, and try to understand what makes them present the disease, or on the other hand, make sure that this young child from a family that has already lost a member due to Brugada syndrome, make sure that he's not at risk, and continue following him up to support him as much as possible and allow him and his family to have a normal life. So this is our aim with all the studies and everything that we have been doing during these last years. So as I shared with you, we started looking into the children with Brugada syndrome in 2017. I started my PhD and I took care of all the families from the cohort of Professor Pedro Brugada in Belgium, in Brussels. He had this great cohort of families and international patients coming for advice from all over the world, but nobody was really taking care of the children, and we didn't know much about them. So when I started working with him as an electrophysiologist, apart from doing the ablation and taking care of pacemakers and doing the classical work, I also decided to look into the children from these families. And I collected more than 200, I think 236 patients, and published one of the first papers in pediatric Brugada, and we followed these patients along the years, and this allowed us to gain experience and to put together a database that started in UK in 2021, and from then I have been collaborating with SADS UK, and then with SADS Canada and also SADS US. So this is about creating a network of doctors whose interest is the well-being and the health of their patients, especially those with inherited cardiac conditions, and in my case, with Brugada syndrome. So we are now trying to understand a little bit the genetics of the disease that could predispose to very early onset of the disease. And we have here Einstein, who said, God does not play dice with the universe. in the sense that there is always an underlying cause for every event. But then we have also Stephen Hawking that said, not only does God place dice, but sometimes he throws them where they cannot be seen. And they are both right. So we know now that we have the main sodium channel, which is the main contributor to the disease. But we know as well that there are modifiers, which are small genes that alter the currents, not only of sodium, but also potassium and calcium within the cell, that can unbalance and push and trigger the onset of arrhythmias of a channel that is already dysfunctional. That means that we have the main sodium channel that is not working very well, but other small contributors that go unnoticed and alter as well other currents of electrolytes within the heart, push the patient across the threshold that can trigger the arrhythmias. So this is what we have been doing so far. And we have published recently some of the data from the initial cohort of last year that included 173 patients collected from 11 centers. Half of them were males, and they were quite young. The mean age of presentation was in between 8 and 9 years old, with a mean age of diagnosis at 10 years. So see how it takes at least 1.5 years since the patient presents with disease, with syncope, with loss of consciousness, with seizures, or even sudden cardiac death. It takes a mean of at least 1.5 years until we reach the diagnosis. Why? Because we don't suspect it from the beginning. Many of the patients are being followed by neurologists or by pediatricians with diagnosis of syncope, and without knowing that underlying this syncope is an arrhythmia that is triggering the loss of consciousness. And we have compared different families that have a positive gene and families that, even if they present Brugada, we still do not know the gene that is causing it, and other families that had inconclusive genetic tests. And that allowed us to understand a little bit the genetic background of the disease, specifically in children that present very, very early and very, very severely. And we have identified where in the gene, this is the diagram showing the channel, the NAVIX is called of the name. This is the sodium channel, and that is constructed with the information in the SCN5A gene. And we have identified where are the different spots that are expressed mostly in children that have severe disease. And we have identified that they're mostly in the pore region of the channel. This is the whole channel, and it has the door in the inside, and most of the children that present with very early and severe disease, the abnormality is within the pore of the channel. So this is what we have already been able to identify, but there is still much more that we need to understand. So we now know that Brugada syndrome is an entity by itself, and that it can manifest very early, because when I started to say this in 2016, 17, 18, and when I was sharing information about children dying of this disease, and I was sharing this at medical conferences, people were coming to me and were telling me, no, this is not possible. I have worked in electrophysiology for many years. I have never seen that. And these same people at the beginning were reluctant to believe this, are now coming to me and said, you know, that patient that I had 7 years ago that didn't have a diagnosis and that had sudden cardiac death, we finally got the extended gene panel, and he has or she has a sodium channel mutation. So now there's more awareness in the medical community about the disease. So we're having more diagnosis, not only in children, but also in adults. And also we have new technology available. Now we have ICDs everywhere. people know how to perform reanimation CRP, so children are surviving and are reaching to us, and they're having a second opportunity to start a new life with a correct diagnosis that can help them survive. We know that there are some common features with the adult disease, but there are also very individual features of children, and we have to understand those more, because up to now we are using all the score and stratification and ICDs typical for the adults. And I think that we have also this notion and these difficulties with Timothy syndrome, for example, and we have discussed at length with Catherine how ICDs are not appropriate for our children, and unfortunately are the only means that we have up to now to make sure that they're protected. But we have to really invest and devote our efforts as a community to do research in minority populations, which are mostly women and children, so that we can really understand what triggers the disease so early and how to preserve their lives. So we have children, very rare children, where the disease can manifest very, very early and be highly lethal with a very rapid progression. And this is the children we have to make sure that we identify. There's a way to unmask the typical ECG, because sometimes, and most of the time, it is not present for diagnosis when patients come to clinic. And we have a provocative test that is a drug that is administered by a vein, and that can unmask, sorry that this keeps moving forward, and can unmask the abnormality of conduction in the channel through an ECG marker that's called type 1 ECG. So we need to make sure that we understand when we can test children and how to test them safely, and also extend genetics in children, not just do the normal panels, because that doesn't allow to diagnose all the children, but make sure that we have a comprehensive understanding of the complexities of genetics in children. And also understand how other concomitant modifiers like fever and viral infections that can incorporate into the DNA push in a way the trigger to develop the arrhythmia. Most children that present with lethal arrhythmias or events have a viral infection. This little girl, Ellie Rose, had a co-infection with 3 viruses: coronavirus, rhinovirus, and enterovirus, and the 3 together, these are all viruses that incorporate their own genes into the DNA of the child. They, in a way, unbalance the DNA, modify further the expression and the function of the channel, and trigger the arrhythmias. And in the beginning, we thought that it was just fever, but it's not just fever. It's also the fact of having a viral infection. In her case, she didn't have fever, but she had a co-infection with 3 viruses. So we are looking into all this information to try to provide a risk stratification model that incorporates genetic information for children. So we have now this registry. We have collected already, this is from last year, but we have now 25 centers all over the world that are inputting data and collecting actively patients. And the information from this last updates up to today is that we have more than 50 centers that have enrolled from 5 continents. Now 17 centers have started to introduce data, and up from a meeting from yesterday, we have now more than 300 patients that have been collected. During the last week, we have from the last week of January, we have collected 100 more patients, and we have a lot of centers that are struggling to get legal agreement. It's more and more difficult to have shared agreement between institutions. The aim is to collect this year at least 500 patients during 2025 and to extend it to 1,000 patients until 2027. We have published a survey last year. We have published another paper in Europace 3 months ago. We have opened the possibility of self-enrollment, and this is a new thing. Patients can enroll through the website if sometimes there's a center where they're not willing to participate, or eventually it's a lot of paperwork. They don't have a legal department to activate this. Patient can contact us and can self-enroll, and through with or without their doctor, we can allow them to be part of the study and to contribute to this project. These are the sites that are active and working, and I have already introduced data. As I said, the most difficult point is the agreement between the legal teams of the institution. So this is what is now withholding inhibiting us from advance at very fast steps. We have some patients have already their data collected but cannot share it with us because of this limitation of agreements, with very high standard now from the European countries that are centralized under a common legislation, and with sometimes clauses that are not completely accepted from our own legal team. So this is giving us a lot of complications. But the good news is that we are also proposing patients and families to enroll on their side. And when a patient decides to enroll in a study, we don't have to go through all the legal aspects of data sharing that complicates all the collaborations and the agreement between international institutions. So we launched our website already a year ago. SADS Canada and UK, and I think that also SADS US are part of the website. They appear as collaborators. And I wanted to mention also my whole team. We are 3 ladies working together. We have Christine Stratman. She is doing her fellowship in pediatric cardiology in Berlin, between Berlin and Munich in Germany. And she is taking care of mostly the European centers. And she's collaborating and helping with patient enrollment at the different centers across the world. And we have Rocio Gutierrez Rojas, who is our senior expert in all the ethics and legal aspects of the database and enrollment. So we work together, and we are supporting this both enrollment of patients through centers and institutions, but also self-enrollment. We have this link to our website. This is a secure code that you can use to access the website, and that is an easy way to reach us, contact us, express interest, put forward questions, and be in touch. And I think that this is all that I wanted to share with you today. I wanted to make it brief because I know that we're a small group, but people that are here may be interested in asking questions. And I thought it would be a nice opportunity to open the discussion and to have a more informal way to interact.
Fantastic. Thank you so much, Dr. Gonzalez Corcia. And if anybody has a question, you can put it in the chat box or you can unmute yourself to ask it verbally. I'm going to start by just reading what we have in the chat box, but feel free to unmute yourself and ask your question at any point. So we have one question so far. If my husband has Brugada syndrome, should my children be tested and should they get genetic testing?
Well, this is a very good question because it's a question that every family has. And the response is yes. The response is yes by my own experience. What I'm trying to do is to gather the data so that we can put forward and make it part of recommendations at a more international level. What we do at this point is, if there is a Brugada diagnosis in the family, irrespective of if there is genetic identification or not, and if the expression has been just through an typical ECG or through the spectrum of sudden cardiac death, we recommend that children are evaluated. Genetic testing, if you know that only in 40% of families with Brugada syndrome, there is a gene that can be identified. So the majority of our families do not have a diagnostic gene. Irrespective of that, I think that it's very important that the children are referred to us, that we do an assessment including ECG, echocardiogram, Holter, exercise test, that we have a link to the family to tell them, look, everything's normal. These children are taken, are being monitored, taken care of, that we can have an open discussion with the family about their risks, reassure them, and eventually start following these children throughout childhood and also into adolescence, where we know that the risk may increase, and this risk is higher in those families that have young children with a genetic variant. In terms of the genetic test, our advice and some expert consensus advice is for genetic testing in early life. Okay? There are still some voices that speak against genetic testing early because they advocate the right of choice of the individual. So some geneticists still say children need to have the right to decide whether they want to be tested or not, because mostly we know that this disease, if present, will manifest later in life. And this is the complexity of Brugada syndrome, because when we speak about other forms of disease, like long QT, like CPVT, because they can express very, very early, and they're mostly diseases that become symptomatic in early life, we don't doubt about testing. But because Brugada syndrome, in most of the cases, but not all, has a tendency to present later in life, some experts still recommend giving the children the choice of a decision. So what I do myself is I have this discussion with the family, because at this point it's almost philosophical. It has to do with a perspective of life. So we sit together and we discuss with the families what are the pros or what are the cons of doing a genetic test. And the cons are mostly related to insurance possibilities. And this is also a realistic thing that needs to be discussed. And from my side, because I monitor these children closely, I leave them do a normal life. So they will not have any sport limitation. Of course, we'll give recommendations in terms of medications and periods of fever. But apart from that, they will be able to carry on with a normal life. So I know that maybe this was a very, very long response, but I think that it's interesting to have this open discussion. And in the end, to summarize, yes, my advice is that children are seen by a pediatric cardiologist, and if possible, electrophysiologist or with expertise in inherited cardiac conditions, and genetic testing is a possibility to be discussed with the family so that there's a share agreement and plan of action.
Thank you very much. Our next question is, should children who are suspected of having Brugada syndrome receive an EP study? If so, at what age should this be performed?
Yes, that's also a very, very, very interesting question. What we do actually before doing the EP study, because what we call an EP study, an electrophysiology study, is to test the electricity of the heart. And for that, what we do is for children under general anesthesia or deep sedation, we go through a vein into the heart and we stimulate the heart and we see the potential for this heart to develop arrhythmias. What we call the ventricular stimulation has been very controversial in adults. We believed in it some years ago. Now we don't believe in it so much, but there's some other data that says that maybe we should believe. So we don't really know in adults. For children, it is very rare that I do an EP study. I don't really need an EP study and to tell which children are at risk. We already know it, and we see it in the ECG, and we see it in the response to the provocative test. That is the other test that we have to discuss about. This is the test where what happens most of the times is that the channel is like a little door that opens and closes, and sometimes it has a minor defect that allows it to open a little bit, okay, and work well under normal circumstances. But if there's fever, if there's an infection, if there are drugs that push the door over the threshold, it gets stuck. I compare it to a revolving door in a supermarket, where most days, like today, a snowy day here in Quebec, if you go to the shopping center, probably there will be nobody. So if the revolving door works, it's a little bit stuck, there won't be a problem. Now, if you go on Black Friday, with all these people wanting to cross this door, very probably the door will get stuck. This is the same with the channel. The channel may be abnormal, but function more or less well until there's a trigger that makes it get completely stuck. Okay? And this is what we do when we give this substance that is called ashmalin, no? Or we have different drugs that are used in different places of the world. But mostly what we do with this is we give a drug that blocks a little bit the opening of the channel, and then we see that in fact it was not working well. And again, I don't advise doing this test in all children, but in selected children, it may give us additional information to either reassure the family or tell them we have to be a little bit more careful with your daughter, your son. So we evaluate this in individual basis up to now, because we don't have guidelines that can really predict this in general. No? We cannot say all the children have to be tested in adolescence, or the children who had a family member that had sudden cardiac death have to be tested. We don't have this kind of information yet to make recommendations that are universal.
Thank you very much. Megan is sharing that she has lost a child to Brugada and has a child with Brugada syndrome who is living as well. She wants to thank you for doing this work and for the presentation today. And thank you, Megan, for joining us. And we're so sorry for your loss. And please let the Canadian SADS Foundation know if there's anything that we can do to help or to support you. Then we have a question. How do I know if my child has Brugada? What are the symptoms?
I want also to show you in embracing Megan and also telling her how brave she is to be here and to be fighting for her other child. And she's always welcome to contact us and to be in touch if there's anything that we can do to help her. It's difficult. To do a clinical diagnosis of Brugada is difficult. The children that I have seen many times have a dysfunction in the sinus node, so they usually start having what we call breath-holding spells. Yeah? So many children, and we're putting together the information for a paper on this. Breath-holding spells happen when the child is frustrated or have pain, okay, and start to cry, and then by the action of a nerve that's called vagus, there's a drop in the heart rate and the child loses consciousness. Okay? And this is normal. Pediatricians see this a lot, and most children have this as a temporary stage in their growing, and sometimes it appears around 18 months and then disappears through 3 years old, and child do well. However, if children have a dysfunction in the sinus node and they have a breath-holding spell, the sinus node cannot kick in and respond in time. So these breath-holding spells can be very severe, can come with seizures, can be difficult to manage, and can extend beyond the normal age. So I have had many children diagnosed with Brugada syndrome because of very severe breath-holding spells. Yes. So this is a marker. Repeated in smaller children would be breath-holding spell. In older children would be mostly palpitations and loss of consciousness. Yeah? And this is most difficult when the child is the first in their family to have the variant. He's the first where the genetic anomaly occurred, because we don't know of it, so we're less attentive.
Thank you very much. And Charles, did you just raise your hand? Did you want to ask a question? You can go ahead and unmute yourself and ask it verbally if you'd like. Oh, here we go.
Yes, okay. Hello, my name is Charles Rolichek. I'm a pediatric cardiologist. I practiced for 30 years. I'm now retired, and I see a lot of outpatients. Syncope is a big seller. I see a lot of patients. And throughout my career, I've always done an EKG on every patient I see. I can weed out the adolescents who are having vasovagal syncope. I see patients with breath-holding spells. And now my concern is, okay, I can find atypical syncope. I can, I do an EKG, it's normal. Now, at what point do I send this person for EP consultation? It's not easy. The same with breath-holding spells. A very typical breath-holding spell, the EKG is normal. I send a patient for EP consultation. Well, great, but at least in Quebec, until recently, literally very few pediatric electrophysiologists, and the buck stops with me. So how do I diagnose this weed out Brugada, which is in the end a rare disease from a very common problem of syncope?
Charles, I really congratulate you, because you have synthesized the problem that we have. We have a lot of patients with syncope, which is mostly vasovagal. We have a lot of patients with breath-holding spells. Maybe 1 or 2 of them may have Brugada syndrome. How to really identify those patients? And we have to be very attentive to the ECG markers. What I look for is a broadening of the P wave, a prolongation of the PR, okay, a fractionation of the QRS, If those are there, instead of saying, well, this could be normal, I would pay extra attention to this child. Because usually what I have seen is if they have already sinus node dysfunction, because in the end, what causes syncope of the breath holding spell is the impossibility of the sinus node to recover. Now, with the trigger of the vagal suppression, they cannot recover. If they have sinus node dysfunction, the atrial is already having some changes, some fibrosis. So that means that there must be a very subtle delay in the conduction, a very long P wave, or the PR interval, or the QRS. So these are the subtle things that I look at, and that's why also we are gathering this cohort to start applying AI over the ECGs. And this is another point that I don't want to go into because there are many branches, but we are looking at our normal ECGs because, as you say, I have never seen a child walk with a type 1 ECG into my clinic doing well. They have the type 1 ECG after they have presented the arrhythmia, and we know that it's premonitory of an arrhythmia onset at type 1 ECG. So we have to look at these other markers. The other thing is if you doubt and you do a Holter, do they have sinus node dysfunction as chronotropic incompetency? Okay, these are children that usually do well. They're not very sportive, maybe, but they cannot go above 180. At maximal exercise, they're limited in their maximal heart rate during exercise. This is the other one. Or the opposite. During sleep, you see pauses. And again, this is another problem with the typical very sporty adolescent whose heart rate is 35 because he has a huge reserve. And when he goes at night, he has pauses of 3 seconds. So this is where we have to keep attention up and look for small markers. Yes. Oh, this is.
Thank you very much. And we have time for one more question. So I'm going to read the next one in the chat that was up. This is from Lisa. She says, "Hi, Cecilia. You diagnosed my son Flynn 3 years ago in Bristol. He is nearly 13 now. Can puberty have an impact on a child with Brugada?"
Oh, this is a great question, and thank you for joining from UK. That's great. And yes, what happened is that as everything, when there is an eye looking, the cases appear. So during my time where I was living in UK, we identified several families with Brugada where we have the problem being the children. And then now the same is now happening in Canada. Now, since I arrived here, I started to look at families. I started identifying that this child that was collapsing, in fact, had an underlying diagnosis, or this child. The other thing is atrial fibrillation. Early onset of atrial fibrillation has to have a genetic test for Brugada. Yeah? And it's good to know that families are still being followed and that they're still, in a way, keeping in touch. So thank you. And yes, the question is actually very, very important because we know that testosterone is a big trigger for expression of the disease. We don't know how, but we know that that is the fact that makes a difference in expression in adulthood, is the fact that men have more testosterone, and in a way this interferes with the expressivity of the channel. So yes, if you have a child that has Brugada syndrome, we have to be especially cautious during the years of adolescence. And sometimes the difficulty is that children also do have syncope. And because there may be some mild sinus node dysfunction, they are more prone to have vasovagal syncope. And then we start asking ourselves, did he lose consciousness because he had low blood pressure and the sinus node did not kick in at time, or did they lose consciousness because they have a ventricular arrhythmia. So if there has been markers that that your child may be expressing in a way the disease, or if there has been a family member that has died suddenly and he has the same variant, and there is a possibility through the period of adolescence of monitoring him more intensively. And this could be with Holters and exercise tests. And if we have doubts, this could be also with an implantable Holter. That's called implantable loop recorder. I tend to use them a lot because it allows, in a way, people that do non-invasive cardiology tend to say, this is very invasive. But I know what a powerful tool they are for families that have had already somebody that died suddenly and that want to make sure that we are not overseeing any arrhythmia that could be unnoticed. And it also allows the children to have a more normal life, because we are sure that we are not missing any abnormal rhythm. So yes, this is another. So the 4 questions that were shared are excellent, and also tells us that we have an audience as doctor and family members that start to understand the complexity of the disease. And I can give you my perspective of experience, but what we have to build together is to have the data to show this, so that we can protect these children better.
Wonderful. Thank you so much, Dr. Gonzalez Corcia, and thank you to everybody who joined today for your time. I know we had a couple of questions left at the end, so please feel free to send any unanswered questions to info@sads.ca, which Pam put in the chat. And Pam is going to go ahead and I saw you raised your hand, so go ahead and get the ending piece.
So I just wanted to say thank you to everyone for attending today. This was a terrific attendance. Thank you to Anna and the US SADS Foundation for helping us out with hosting this important event. We will have it available on our YouTube channel in the next couple of days, so you can certainly review it with friends, family, direct your physician, your own physician to this very important information. And for sure, info@sads.ca, please send an email at any time and we'll get back to you. We can forward your questions to Dr. Gonzalez Corcia for her attention. And so, yeah, on that, I think I'll end it. And thank you to Dr. Gonzalez Corcia. You're always so delightful. I'll call you Cecilia. And
yes, please.
thank you to everyone.